Up next, I would like to invite on stage Dr. Sashikant. Please welcome him with a big round of applause. Also, may I request all the speakers to kindly hand over your slides to the console out there. This will help us save time. Thank you.
Good morning, everybody. So when you fail to intubate with a reused catheter, probably using a new catheter would make a lot of difference. So my topic today was right coronary artery guide catheter selection, the cannulation and technical issues. You know the guide catheter anatomy, it's stiffer, it's having a larger lumen, has got a shorter and more angulated tip. That's very, very important when compared to the diagnostic catheter. And of course we all know the slides. How is cannulation of the right coronary artery different from the left coronary artery? This is very important. We don't take a backup support both in the femoral approach or as from the radial approach. The support for the right side is much less. Basically it's a passive support which is used for most of the procedures unless you have a definite indication where you have a CTO or a very proximal location of the occlusion wherein you have to use some active supports. Why do we need so many sizes and shapes, both for the left or the right system? The no two anatomies are the same. You have large or small patients, you have small or enlarged aortas, you have different vessel takeoffs and sometimes the grafts. Here is an example from the right coronary artery wherein you have a horizontal takeoff of the right coronary artery, you have an inferior takeoff and you have a Shepherd-Crookes takeoff. So these anatomies define which guiding catheter you would use in coronary artery. Now engaging the right coronary artery with the amplats is a little difficult, little risky because it can dissect out the ostium. Two important points when we do this: when we engage the right coronary artery, sometimes the guiding catheter flips into the cornus branch and you have dampened pressures. What you need to do is detorque counterclockwise a few millimeters and you would have and pull back a little bit, the guiding catheter falls into the right coronary artery and it would avoid engaging the cornus branch. Here are a few radial curves which I have not used but have the easy radial right, the RRAD and the MRESS, which are the catheters which are used. This is one catheter, universal transradial curve, wherein you can do both the diagnostic and interventional procedures through the same catheter. You can take the left ventricular EDP measurements, you can engage the right coronary ostium with a gentle clockwise torque, and as the catheter is slowly advanced, it engages the right coronary artery. You can with the same catheter do the procedure on the left side also. So this is the universal transradial curve, basically used for the radial curves, for the radial procedures, and some less traumatic, less or passive guiding catheters are the all-right catheter as well as the Keyes right superior catheter, basically both for the horizontal takeoff of the coronary artery with the proximal or very ostial location of the lesion. A Shepherd-Crookes RCA, a very acute angle there, very difficult angle there, so you can use an AL1 or a 3D RC catheter for this Shepherd-Crookes anatomy. We have gone through this. A 6 French catheter definitely has got an advantage of a smaller puncture, less bleeding, but most often when you're doing a complex procedure needing a lot of support, one should prefer to use a 7 French or an 8 French guiding catheter. It allows you to use some of the covered stents in case you have a perforation in a CTO, and definitely it's very important that the rotablator and double kissing balloon techniques, definitely a larger guiding catheter will give a better opacification, better guide support, and also carries a risk of ostial trauma and vascular complications. This is the new guiding catheter we were just talking about. This is a hydrophilic sheathless catheter which is used. We don't use the sheath, and we can use a 7.5 French catheter is equal, outer diameter is equal to less than a 6 French sheath. So this is a new one which can be used both for the right and the left. They are available today. We have gone through this before. Let's just spend 1 minute on this particular slide. The takeoff of the RCA decides the choice of the guiding catheter. With a normal takeoff, you can use a horizontal takeoff. You can use a JR, Judkins right, or sometimes even an EBU procedure. You have done a left procedure, the same EBU catheter can be pulled out of the left coronary catheter, do a clockwise rotation, and the EBU simply goes and sits into the right coronary artery. It's not very difficult. We've done some procedures like that. A superior takeoff, usually the guiding catheter of choice is AL1, amplats right, the hockey stick or the internal mammary artery catheter, which has got a little sharp angle wherein the catheter goes and hooks the ostium of the right coronary artery. The Shepherd-Crookes can be tried, the XB RCA and the smaller curve JR. Instead of JR 3.5, you can use JR 3. It tends to hook the catheter much easier. With an inferior takeoff, it's a JR short tip or a multipurpose catheter or an XPR. And with an anterior takeoff, AL1 or 2, with a larger curve Judkins again can be tried there. In place of ostial RCA lesions, to avoid an cath engagement of the ostium RCA and producing a dissection, we avoid an Amplatz curve and preferably remain in the sinus and try to wire the lesion while remaining in the sinus. That would be a better decision to do. Very, very important. When you look at the takeoff of the RCA and the choice of the catheter, the views which are important are the LAO 40 view and the left lateral view. These are the best views to engage the catheter. Sometimes you're not in the right sinus, you're in the non-coronary sinus, and you keep on rotating the catheter. The best would be to go switch out to the left lateral view and engage the catheter. That's the most anterior part. You'll have the right sinus as well as the coronary ostium there. Of course, very important to remember, there's a higher radiation dose when you do your manipulations in the left lateral view. And sometimes when you have the right coronary artery coming from the left sinus, you can use a larger curve Judkins left or an AL1, AL2, sometimes even a multipurpose catheter. And if you have a posterior takeoff, AR1, AR2, AL1 or AL2 are the Amplatz catheters are the catheters of choice. The three-dimensional right curve catheter is especially useful when you have a tortuous bent anatomy and a posterior or superior takeoff of the RCA. Very, very important when you do an RCA procedure, especially with the Judkins, you have minimal support. It's a passive catheter. What you need to do is be coaxial and take enough support. And the minimal thing what you have, and the passive is the Judkins right, but if you want a more active support, you need the AR1 or 2, and if you want still more active support, the Amplatz left system or the hockey stick gives you definitely much better support. So how do you get a good backup? Use a larger catheter size. You have to use a coaxial alignment. Lots of times the catheter is not co-aligned, so your devices, balloons or stents don't go in, so you just need to do a little clockwise rotation, get a coaxial alignment, and most of the times the device slips into your coronary artery. Of course, sometimes you need to do a deep intubation of the catheter, with the catheter into the vessel, and that's the active support. We'll show you a few cases down there. And sometimes you need to be taking a stiffer catheter of different companies to get into this system. I personally don't like side holes. In fact, I have not done a single procedure in the last 10 years with side holes. However, you have the false security that probably you're looking at the pressure, but what you're actually looking at is the aortic pressure and not the true coronary pressure. And you have a suboptimal opacification, and of course the backup support may be a little weaker because the shaft is becoming a little weak there. Certain guiding techniques for doing a PCI of tortuous arteries, you need to deep seat your guiding catheter. In fact, what you're doing to do is become coaxial, go to RAO 30-degree angle, see that the catheter is coaxial, and then come back to a LAO view and start doing a slight clockwise rotation and push the guiding catheter deeper in so that over the guide wire, in fact, or the shaft of the balloon, wherein the guiding catheter can be pushed almost up to the mid-RCA or distal RCA sometimes. Of course, we stand the risk of having a dissection or embolization, especially in a degenerated saphenous vein graft. This is one example wherein you need to do a deep setting of the guide. The catheter is sitting here, you put in a wire, and on top of the wire you can do a clockwise rotation of the guiding catheter. With a shepherd crook, it's a little difficult to get a deep seated position, but for a horizontal takeoff or for an inferior takeoff, you can just do a clockwise rotation of the guide catheter and push it gently down, and you can take the catheter down up to the mid-RCA, or in a few situations wherein you can put the wire across the lesion, balloon in the lesion, inflate the balloon, take the support of the inflated balloon, and then push the guiding catheter down to push your devices down. One can use the child and mother technique, wherein you have a 5 French guide and a 6 French or 7 French guide catheter, and lots of times, almost 70% of the situations, you can definitely push in most of the devices. So what are the maneuvers you do to increase the support? You could change the guide, you can deeply insert the guide, you can use an anchoring guide or an anchoring balloon technique, or insert a 5 French guide into the guiding catheter. This is one example wherein we thought probably we were coaxial, and when we did the second injection, GERD injection, again we thought we were coaxial. The third injection was done, and you see what happens. There's a spiral dissection just going down completely down to the distal RCA. So what you think is coaxial in the LAO view probably may not be coaxial in the RAO view. So if you are taking a procedure and you think your angulation is not correct, probably you need to go to the RAO 30 view and take a view and decide if the guiding catheter is coaxial. So one example where in a very proximal location of the guiding catheter, you need to sit outside the vessel and then wire the vessel sitting outside, not to engage the guiding catheter in deep, and then it can be done with the procedure, staying outside the ostium of the coronary artery. A very tortuous aorta, you need to sometimes put in a very long sheath to engage your the right coronary artery with the standard guiding catheters. This is one example wherein the guiding catheter is sitting in the sinus and we try to wire the lesion through the sitting in the sinus. The procedure was completed successfully with the catheter. This is the last example I'm showing you. This is a patient we thought at evening 5 o'clock we have taken up the patient, 2 stents, spot stenting in the mid RCA, and we thought, look at this angle there. It's not a very good angle between the guide catheter and the vessel there. And we thought probably we are doing well with this procedure. We wired the lesion, we did a plain balloon angioplasty, the mid RCA, plain balloon angioplasty in the distal RCA, and here we are coaxial. Look at this angle between the RAO 30 view. The guiding catheter and the vessel are coaxial. We did a stenting of the procedure, the mid RCA. We did a stenting here and we put a stent here, and there's a dissection here in this part of the vessel. So we thought probably we can put one more stent distally and be done with it. Look at the guiding catheter, how it has got disengaged. As we're trying to push in the I'm sorry. So we just tried to push in the balloon and the guiding catheter got disengaged. And this is the amplification technique of the Judkins right, wherein we pushed in the catheter and do a little counterclockwise rotation. You amplify the Judkins right and engage it deeply. We could push the balloon down, we could push the stent down, stent the vessel, and did a little bit of more deep throating of the guiding catheter. And we could, I think it's going back. Okay. We did a little more deep throating of the guiding catheter, a little more amplification. Look at that. The patient had a VF. The patient had a VF and the entire system had to be pulled out because there was no flow in the coronary artery. The patient had to be shocked, reverted immediately, promptly, rewired the vessel, and again took a shot, and we had a good result finally. So what is important, the take-home message, a guiding catheter coaxial alignment is very important for the right coronary artery. An RAO 30 view is very important, wherein you see the end-on view of the tip of the guiding catheter there. And of course, LAO 30 view is very important for the proximal vessel orientation. A 5-inch guiding catheter is very handy, very helpful, but very important. There are more instances of air embolism happening because it's a 5-inch catheter. With every passage of a device through the balloon, through the guiding catheter, you need to de-air your system. Arterial pressure damping, we have had Dr. Kapati talking about this, but very important again, especially for the right coronary artery, an ostial plaque, a spasm, or a non-coaxial guiding catheter location is very important, or a catheter in the conus branch is again very important there. There is no typal lesion or a sitting duct lesion. Handle the vessel carefully. In fact, my boss says, caress the vessel and treat it with a lot of respect. Review the angiofilm multiple times before you think about the strategy of active or passive support. Lack of guiding catheter support could be frustrating. Choose wisely from the various shapes. Be familiar with one or two guiding catheters rather than with multiple guiding catheters. And deep throating and amplification to be done when necessary, only when necessary. Be prepared for an extra stent at the ostium. Of course, there are various ways you can avoid an injury to the ostium. Thank you so much.